Hello and welcome to my YouTube channel. I hope all of you are doing very well. Today we would be discussing a very important topic which can be considered as one of the number one enemies of any surgeon, and that is surgical site infection. This is a very important topic because any patient who has been operated with clean aseptic conditions and with proper post-op care may still go on to develop surgical site infection, and that not only prolongs the hospital stay of the patient but also increases the cost of the treatment as well as occupying one bed which could have been utilized for some other patient, and not only does also delays the return to work for the patient. So all in all, surgical site infection is, from either a minor or a major surgical site infection, does cause a lot of disturbance, both physical as well as psychological, and it also prolongs the hospital stay, it prolongs the cost of the treatment, it increases the cost of the treatment, and it leads to a lot of other complications as well. So without wasting further time, let's go deeper into this very important complication which can occur in any surgical procedure, and which should be initiated a treatment as early as possible to prevent further complications. Now, first and foremost is, what exactly is surgical site definition? We would go on to discuss that, and the latest CDC, the Center for Disease Control classification of surgical site infections. Now, the CDC definition of 1992 initially defined surgical site infection as occurring any infection occurring within 30 days of surgery or within 1 year of any surgery if an implant was used. Now, that was an older definition which has been modified in 2017. So, now the latest definition includes 30 days of infection, any infection of the surgical wound which is occurring within 30 days post-operatively if no implants are used, or within 90 days if implants are used. Now, implants can be any hernial mesh. It can also be any orthopedic implant which can be used like in total hip replacement or total knee replacement, or any type of implants which has been kept in place or left in place. And if the infection of the surgical wound occurs within 90 days of that, then it would be considered a surgical site infection. And if no implants are used, then the time frame is 30 days. Now, this surgical site infection can involve different anatomical layers depending on how severe is the infection. So it can involve just the skin and subcutaneous tissue, or it can go on to involve the fascia, muscle, or even the organ space infection. So first and foremost is the superficial. If we classify according to the anatomical depth of the surgical site infections, we can have a superficial incisional SSI, a deep incisional SSI, and an organ or organ space SSI. Now, what exactly is superficial incisional SSI? This means that only the skin and subcutaneous tissue is involved in surgical site infection, and generally the time frame given is occurring within 30 days following surgery. Now, what exactly is a deep incisional SSI? When the deeper layers below the fascia, that means the fascia and the muscular layers are involved, then we would classify such type of surgical site infections as deep incisional SSI. And for this also the time frame given is occurring within 30 days of any surgical procedure. And organ or organ space infection would involve any organ like any anatomical cavity open during surgery. For example, it could be a pleural cavity or even a cranial cavity, or it could even be a peritoneal cavity. So any infection occurring within this organ space would be considered as an organ space infection, which obviously signifies a more severe form of infection. So for skin and subcutaneous tissue, we have superficial. For fascia and muscle, we have deep. And for organ space, we consider as any organs involvement or any organ space involvement, we consider as organ space SSI. So this diagrammatic representation would be, you would be able to understand it better. If the skin and subcutaneous tissue is involved, then we would classify such type of surgical site infections as superficial incisional SSI. If the deep soft tissue below the muscle fascia is involved, like fascia and the muscles, then it would be categorized as deep incisional SSI. Now, mind you, in deep incisional SSI, obviously, there may be associated infection of the skin and subcutaneous tissue also. And when the organ spaces are involved, then we call it as organ space SSI. Now, just coming to the epidemiology and a burden of surgical site infection, we have already seen how economically, psychologically, as well as physically it would affect the patient, but also it also affects the entire healthcare ecosystem. So, overall, if you see in an elective surgery, the incidence of SSI would be 2 to 5% is the overall SSI rate. So that means if you do 100 elective surgeries, out of those 100 elective surgeries, 2 to 5 patients may undergo surgical site infection. It is the incidence of surgical site infections in an emergency surgery may be slightly higher than as compared to elective surgery, for obvious reasons that patient may not have adequate preparation time to prevent further complications like SSI. It is number one most common healthcare associated infection in surgical patients. It 3 times longer hospital stay compared to non-infected patients. That's what I was mentioning. It would prolong the hospital stay, and it would also cause a lot of associated physical, monetary, and other psychosocial complications. So it prolongs the hospital stay almost 3 times as compared to a non-infected patients. And 77% of SSI related deaths are attributed directly to infection. So, in a patient who have a certain comorbid conditions in the form of immunosuppression, patients who are on transplant drugs, patients who have long-standing diabetes which is uncontrolled, or patients who are on immunosuppressive medications on malignancy or chemotherapeutic regimens, they are predisposed to increased mortality, and 77% of death, SSI related deaths, are directly attributed to underlying infection. SSI rate, if you see by procedure type, surgical procedure type, all of you know that there are 4 different types of surgical procedures which are broadly categorized as clean surgery, clean contaminated, and dirty surgery. Now, clean surgery, as in say a laparoscopic laparoscopic hernioplasty, mesh hernioplasty, or any surgery which does not involve any contaminated material. So that type of surgery, like clean surgery, the SSI rate is very low. It's to the tune of about 1 to 2%. In patients with clean contaminated, like appendicectomy, which is not perforated, uncomplicated appendicitis, clean contaminated surgery, the rate of SSI increases to 3 to 11%. Whereas contaminated surgery, so if you're doing a gut resection, or if you're doing any infected conditions within the abdomen or a pleural cavity, in that case the SSI rate would increase to about 10 to 17%. And in a dirty, like if you're operating on a patient who already has a purulent or a feculent peritonitis, it's one of the examples of dirty surgery. In that case, the rate of SSI may go even beyond 40 to 50%. So the rate of SSI would also depends on the type of the procedure, the type of the surgery being done, whether it's a clean surgery, a clean contaminated, or a dirty surgery. Now, coming to the risk factors which would lead to the development of surgical site infections. Now, the risk factors can be classified according to patient related or surgical factors. That means related to the underlying surgical procedure. Patient related factors, the most important factor is uncontrolled diabetes mellitus with HbA1c more than 7 for a prolonged time. That is one of the important risk factor for development of SSI, because diabetes would not only lead to a depressed cell mediated immunity, it affects all components of cell mediated immunity. Also, the wound healing and other complications of wound are frequently seen in patients with uncontrolled diabetes. Another important risk factor is obesity with a BMI more than 30. These patients are also at risk of development of surgical site infections. Malnutrition or hypoalbuminemia would also lead to development of SSI. Any patients who are on immunosuppressive drugs, or because of certain other conditions like steroids, chemotherapeutic regimens, transplant drugs, or patients with certain infections like HIV, AIDS, they also are at risk of development of surgical site infection. Similarly, colonization or active infection with methicillin resistant Staphylococcus aureus is one of the important risk factors. Prolonged preoperative hospital stay has been documented to be one of the important risk factors for development of SSI. That's why a prolonged pre-op hospital stay should be avoided and patients should be admitted as close to the procedure as possible to prevent any nosocomial infection. Any patients with anesthesia grade ASA grade more than 3 or class 3 would be considered at risk of development of SSI. And also the advancing age, elderly patients, patients with peripheral vascular disease or peripheral arterial diseases, they are also at risk of development of surgical site infections. Now coming to surgical factors, any patients who has got a prolonged surgery beyond beyond 4 to 6 hours are at risk of development of surgical site infection. So the longer the duration of surgery, the risk of surgical site infections increases proportionately. We have already seen how procedure classification, whether it's a contaminated procedure or a dirty procedure, significantly affects the rate of development of SSI. Whether it is an emergency surgery or elective surgery, we have already seen that elective surgery, we still have time to prepare the patient for surgery, and the risk of SSI is slightly less as compared to a patient who undergoes an emergency surgery. During surgery, if hypothermia develops in a patient, this would increase the chances of development of SSI. Hypothermia would basically reduce the cell mediated immunity, significant hypothermia, and that would affect the development of post-op SSI. Inadequate skin antisepsis or skin preparation preoperatively is very important factor. That's why adequate preparation, the part preparation plays a very important role in preventing the development of SSI. Failure of antibiotic prophylaxis. If antibiotics are given and if they are given incorrectly in appropriate dosages, or if they do not work according to the patient's requirements, then that can also lead to surgical site infections. Any patient with unnecessary abdominal or any other drain being kept for a prolonged period would also increase the chance of SSI. Similarly, any foreign body in the wound, it could be anything like a suture material or an implant or anything, can also affect the development of or increases the chances of development of SSI. Any hematoma would naturally would lead to increased chances of SSI. That's why meticulous hemostasis during surgery is one of the important steps in preventing a surgical site infection. Leaving any dead space would lead to accumulation of seromas or blood, and that can also increase the chance of development of SSI. That's why during surgery, the dead space should not be left, and as far as possible, the layer by layer closure should be done properly. Now, coming to the microbiology of surgical site infection, the commonest causative microorganisms are Staphylococcus aureus, including methicillin resistant Staph aureus. 30% of surgical site infections are attributed to Staph aureus, including MRSA. Second most common are coagulase negative staphylococci, which accounts for about 14% of cases of SSI. And then we have third commonest ones are E. coli, the gram negative organisms, 9%, Pseudomonas aeruginosa about 8%, Klebsiella pneumoniae about 7%, and then the Enterococcus species. So sometimes most of the cases it's a polymicrobial infection where anaerobes and aerobes together can colonize the surgical wound and lead to surgical site infections. MRSA screening and decolonization, that means mupirocin nasal and CHG wash, is recommended preoperatively for high risk cases. What are the clinical features and diagnostic criteria for surgical site infections? The CDC diagnostic criteria states five important criteria for diagnosing a surgical site infection. Number one is purulent discharge from the incision or drain site. That is the number one criteria. Time frame we already know, 30 days and 90 days with implant, without implant and with implant. Now here, number one criteria is purulent discharge from incision or drain site. Number two, any organisms, microorganisms isolated from aseptically obtained culture. So whenever there is a culture positive from the wound, that is also considered one of the important diagnostic criteria. Number three is pain and tenderness, as well as localized swelling and erythema and warmth of the surgical site wound. That is also one of the important criteria for that means the inflammatory changes occurring on the surgical wound. Wound deliberately reopened by surgeon with local signs and diagnosis by attending surgeon or physician of surgical site infection. Out of these criteria, at least three or more should be present for it to be considered as surgical site infection. So these are the important criteria of surgical site infections. Now coming to the severity spectrum. Grade 1 surgical site infection means superficial surgical site infection, local wound signs only, and generally the such type of patients responds to wound care. Superficial local wound signs only, and such patients responds to wound care. Grade 2 requires antibiotic therapy, systemic antibiotic therapy, but there are no systemic signs here. Grade 3 SSI requires some sort of surgical intervention like a drainage of the wound or debridement of the surgical wound. And grade 4 SSI would be categorized as patient with necrotizing fasciitis or sepsis. Such patients would require surgical intervention and source control. So these are the severity spectrum grades of SSI from grade 1, which responds to only wound care, to grade 4, where the patients have associated sepsis or necrotizing fasciitis. Now, there is a wound scoring system which is known as asepsis wound score. Asepsis is a mnemonic for additional treatment, serous discharge, erythema, purulent exudate, separation of deep tissues, isolation of bacteria, and stay in hospital prolonged over 14 days. So these are the criterias which are used, and for these criterias, the points are given according to these criterias. So if you have additional treatment, which stands for A, additional treatment, antibiotics or drainage of pus under local anesthesia or debridement of wound, all these would be considered as additional treatment for surgical site infections, and for that points are given. For example, if you're giving antibiotics for SSI, then 10 points are given. If you're doing a debridement, another 10 points are given. If you're doing a drainage of pus under local anesthesia, 5 points are given. So accordingly, if there's a serous discharge daily, then depending on the type of discharge, you can give 0 to 5 points. So like that, you give for these criteria different points and calculate the points. If the score is more than 20, then it indicates that the surgical site infection is a severe infection and patient should be admitted, and this may likely to prolong the course of the treatment and hospital stay. And if the score is more than 40, then these patients have serious surgical site infection, and that indicates that patients are at risk of going into sepsis. It also increases the chances of mortality. So asepsis wound score would be a predictive score where it would tell you whether the SSI is a mild, intermediate, moderate, or severe SSI, and what is the course of that SSI. So this asepsis wound score can be used in wound clinics and in surgical wards to predict the course of SSI. What are the investigations to be done when you have a patient of surgical site infection? The first and foremost is for the wound itself, take a wound swab under strict aseptic conditions, especially from the purulent area or necrotic area, and send it for culture and biopsy. We can also do a wound biopsy or a tissue culture. from the wound itself and send it for histopathological examination and culture and antibiotic sensitivity. This would be considered as gold standard for diagnosis of SSI. Do a rapid gram staining as well as blood culture. At least 2 specimens before giving an antibiotics should be taken if you're suspecting systemic signs of sepsis. For blood, you must do a full blood count, which may show leukocytosis with a shift to the left, increased C-reactive proteins and ESR, liver function test and renal function test, and if the patient has comorbid conditions like diabetes, then do a HbA1c and a sugar profile. For imaging in a surgical site infection, do an ultrasound of the surgical wound if you're suspecting any collection or an abscess. In an organ space infection or a deep space infection, CT abdomen or pelvis is one of the important investigations to delineate the abscess cavity, the size of the abscess cavity, the number of abscesses, and you can plan your treatment accordingly. For necrotizing fasciitis, we can also do MRI of the affected extremities. And plain X-ray of an affected limb, especially in gas gangrene like Clostridium, can show presence of subcutaneous gas. Culture before antibiotics whenever possible. Now we go on to see one very important thing. A necrotizing fasciitis, if you remember, would be classified as grade 4 surgical site infection where the patient is at risk of going into sepsis. So necrotizing fasciitis is a separate topic in itself, which we would like to cover in our separate presentation. But just for the starters, I would like to tell you that there is a lab risk indicator for necrotizing fasciitis score, what is known as LRI NEC score, laboratory risk indicator for necrotizing fasciitis. This scoring system is used for necrotizing fasciitis. It has got these 6 criteria: C-reactive proteins. If it is less than 15 milligram, then 0 point, more than 15 milligram, 4 points. WBC count less than 15,000, 0 points, and if it is more than 25,000, 2 points. Hemoglobin more than 13.5, 0 points, less than 11, 2 points. Sodium more than 135, 0 points, less than 135 milliequivalents per liter, 2 points. Serum creatinine less than 1.6, 0 points, more than 1.6, 2 points. And blood glucose less than 180 or more than 180 milligram. If it is more than 181. So if the score is equal to or more than 8, then the positive predictive value of necrotizing fasciitis is almost 93%. While scores of 6 to 7 had a positive predictive value of 92%. Score of 6 or less has a very low risk of necrotizing tissue infections. So this parameter, which is basically a lab risk indicator for necrotizing fasciitis, this scoring system can be used to predict the development of necrotizing fasciitis. Now the main important thing is the management of SSI because this is one complication of surgery which can easily be prevented, and if at all, if because of certain reasons the SSI do occur, then management plays a very important role. Aggressive management should be done so that the patient should not go and further deteriorate and increase further cost of treatment as well as prolonged hospital stay. So the first and foremost steps of management is assess surgical site infection very, very clearly, whether it's a superficial infection, whether it is a deep incisional infection or a superficial incisional infection or an organ space infection, by doing appropriate clinical and pathological as well as imaging modalities to know what type of SSI you're dealing with. The second thing is the management for superficial SSI. The most important thing is remove the sutures and staples immediately and open the wound. Probe the depth, exclude any deep extension of a superficial SSI. Irrigate the wound with saline or betadine, that is povidone iodine. Antibiotic systemic should only be given if there are any systemic features like tachycardia, fever, tachypnea, or any localized significant cellulitis of the surgical wound. Daily change of wound dressing should be done, preferably with a saline dressing or an antibiotic solution. Secondary wound closure should be done once the wound becomes clean with no slough and necrotic discharge, no edema, no inflammation, and no slough. This would take maybe about 5 to 7 days of the above management. Once the wound appears to be healthy, then a secondary closure can be done. This is for superficial SSI. For a deep incisional SSI, it would require a firmer exploration of the wound under general anesthesia, because now the infection has gone below the fascia. So under general anesthesia, the wound should be explored formally, and all the necrotic tissue, slough, and dead devitalized tissue should be debrided. So debridement plays a very important role for further recovery of this deep incisional infection. Leave the wound open, pack it with povidone iodine or other antibiotic solutions. IV antibiotics are generally given depending on culture reports. Culture directed initial empirical therapy can be given, and once you get the culture report, then based on the antibiotic sensitivity, IV antibiotics should be prescribed for at least 7 to 10 days. Sometimes if the wound has got a lot of edema, a lot of fluid and slough and necrotic tissue, then a negative pressure wound therapy like a vacuum assisted closure, VAC, can be used to hasten the healing of the wound, which would reduce the edema, promotes epithelialization, and also increases the wound healing. And later on, once the wound becomes healthy with healthy granulation tissue, then a delayed primary closure or a split skin graft can be used for closure of the wound. So this is for deep incisional SSI. And then we have the third one, and that is for organ or organ space deep SSI. Here you have to do an imaging, either a CT, to know exactly where is the abscess. And then under CT or ultrasound guidance, a percutaneous drainage with a catheter passed into the abscess cavity should be attempted. Surgical drainage should only be done by formal surgery if the CT or ultrasound guided percutaneous drainage is inaccessible. The abscess cavity is in an inaccessible location. IV antibiotics should always be given initially empirically, later on culture guided, and manage underlying source. The source control is very important in organ space SSI. So it could be any source of infection like an anastomotic leak, for example. It should be tackled, because without source control, the treatment would be incomplete. And nutritional support should be given for such patients, because many of these patients are nutritionally depleted. Now, prevention, as I've already told you, plays a very significant role, and better it is to prevent an SSI than to treat an established case of SSI. So, for antibiotic prophylaxis, skin antiseptic preparation before surgery at least should start 2 hours before surgery. That is very important. The part preparation and the antiseptic care of the skin to be operated upon, the part to be operated upon, it should be given due importance, and ideally it should start at least 120 minutes before the operation. 60 minutes before surgery, or some authorities say 30 minutes before surgery, IV pre-op antibiotics should be given, so that when the surgeon is doing the main step of the surgery, that means the peak concentration of antibiotic would be in the bloodstream. Incision, therapeutic level of antibiotic at incision time must be present for it to take effect. And within 24 hours post-op, discontinue prophylaxis. No benefit beyond giving, unless the type of surgery or the patient's general condition dictates a prolonged course of antibiotics. The first choice of antibiotic agents are third generation cephalosporins like cefazolin, 1 to 2 grams IV. And for GI cases, you must also add metronidazole to take care of anaerobic infection. The WHO has come up with a SSI prevention bundle for categorizing into preoperative, intraoperative, and postoperative. For preoperative, SSI bundle is patient bathing is very important. Very important before surgery. Patient should take a warm antiseptic bath. Hair removal, clippers should be used and not razors, because it can cause scratches and increases the chance of SSI. And preferably the clipping of hair should be done at the OT table. MRSA decolonization, nasal swab should be taken and patients should be treated accordingly. Any patients who have got diabetes should undergo adequate glycemic control, and HbA1c should be kept under control. During surgery, warm humidified oxygen should be given. Maintain normothermia. We have already seen that hypothermia would prolong the chances of SSI. So 37 degrees is ideal. Iodine impregnated incised drapes are the best ones. Antibiotic coated sutures as far as possible to be used, and wound protectors should be used during laparotomy. And post-operatively, maintain sterile dressings, avoid unnecessary drain insertions. That is very important, because if the drains are not required, don't insert the drain. It can unnecessarily increase the chance of SSI. And early enteral nutrition would prevent the translocation of the bacteria and further sepsis. So early enteral nutrition and early ambulation should be advised in a post-op case. So this is a SSI prevention bundle which has been advocated by World Health Organization. Now, just to summarize what we have just learned, the SSI timing window we have already seen: 30 days within surgery and 90 days, 30 days within surgery if no implants are used, and 90 days if implants are used. Number one organism for SSI is Staph aureus, 30% are attributed to it. First choice of antibiotic is cefazolin, 1 to 2 grams IV should be given for pre-op. Wound class, highest risk for development of SSI is dirty or infected wound. More than 30% patients may develop SSI. CDC classifies as SSI into superficial incisional, deep incisional, and organ space. Prophylaxis timing: within 60 minutes before incision, the pre-op antibiotic should be given and preferably stopped after post-op 24 hours. The lab risk for necrotizing fasciitis scoring system: if it is more than 6, then suspect necrotizing fasciitis, and patient should undergo urgent surgery in the form of debridement and removal of all devitalized tissue. And post-op dressings, at least it should be changed after 48 hours only. Keep the sterile dressings for 48 hours following surgery unless they are soiled or stained with blood products. So with that, this in nutshell is a very important topic of surgical site infection, its prevention and its management. I hope you have liked this topic. Please subscribe, share with your colleagues, and try to uh, post your queries in the chat box. Thank you for watching. I would keep coming back with more topics in future. Thank you for your time.